This is a role play developed as part of the course curriculum for Manage TB, an online course for doctors. The participants have enacted the roles given to them. The case discussed does not refer to any existing patient but has been developed as part of the course curriculum. The investigations such as X-rays and lab reports used in this case scenario belongs to patients treated at National Institute for Research in Tuberculosis, Chennai. Their identity have been anonymized.
Good morning, sir.
Good morning, Dr. Saranya.
Can I discuss the case with you now, sir?
Yes, please.
So, there's a patient who is a 55-year-old male, building laborer. He has persistent cough for the past 6 months. He has loss of weight and appetite for the past 6 months. He's a known diabetic on oral hypoglycemic drugs for the past 5 years. He's also a smoker and alcoholic for the past 35 years. I also did a thorough systemic and general examination. He has no pallor or clubbing, but he has right upper lobe crepitations. His chest X-ray also shows right upper lobe involvement. We did AFP sputum for him, which came out to be positive.
Okay.
So we send a line probe assay for the first line drugs, and the bacilli is found to be isoniazid and rifampicin resistant.
Okay.
But the isoniazid resistance is only for INHA. So we sent the patient specimen for second line LPA,
Okay.
which came out to be sensitive to fluoroquinolones and aminoglycosides, sir.
Okay. So, what do you think is the diagnosis for this patient?
Sir, I think it's a case of MDR TB, sir.
Okay. So, he's on a case of MDR TB. So,
Yes,
do you
sir.
have any more information from this patient?
Sir, I asked his previous drug history and it's found that he has taken ATT for a period of 3 months 2 years ago. But then he relocated to some other location and he also found that the symptoms has gone. So he stopped using the drug.
Okay.
But then the patient has not used fluoroquinolones or aminoglycosides during the 3 months period of ATT, sir.
Okay. So, now having a case of MDR TB, what are the treatment options you have for multi-drug resistant TB?
So for this patient, we will go for short oral biraculin therapy, which is for 9 to 11 months duration. But there is also a long oral therapy, MDR-TB therapy, but that is for a duration of 18 to 20 months. And that is also given for patients who are both isoniazid INHA and CATG mutation with rifampicin mutations.
Okay. So, you are saying you are going for shorter regimen because
Yes,
of the mutation. Can you
Yes, sir.
explain it again?
So the patient is having mutation for rifampicin and INHA of isoniazid.
Okay.
So
Good.
we are going for a short oral biraculin containing regimens.
Okay. Oh, good. So, what all investigations you will do before starting treatment for this patient?
So we'll go do a HIV testing and we'll also do complete blood count and we'll do the liver function test, thyroid function test
Okay.
and serum creatinine, blood urea, and we'll also do ECG
Very good.
and we'll go for mental health evaluation also, sir, for this patient.
Very good. So, mental health evaluation will also be done. Do you think we need to do audiometry for this patient?
So for this patient, it might not be necessary because this patient is not taking aminoglycosides. If we are giving aminoglycosides or any other autotoxic drugs like in long oral MDR regimen, then we might go for audiometries.
Okay. Now that we are assuming all the investigation comes out to be normal.
Okay.
So, how we are going to plan the treatment for this patient?
So for this patient, the short oral biraculin containing regimen will be started for a duration of 9 months, but it can be extended to 11 months based on the sputum results at the end of the 4 months. The regimen will have initial 4 to 6 months of biraculin, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose isoniazid, ethionamide, followed by 5 months of levofloxacin, clofazimine, pyrazinamide and ethambutol alone. Irrespective of the sputum results, biraculin should be given for an initial 6 months durations.
Very good. So, now can you tell any contraindication for these drugs or treatment?
So for patients who have extensive parenchymal involvement, lung parenchymal involvement, or if there is bilateral cavitary lesions, or in case of pregnant females or child less than 5 years, or if there is any contraindication to biraculin use,
Okay.
then we will have to consider longer regimens, sir.
Okay, good. So now can you explain what is there in the longer oral regimen?
So, MDR patients who are excluded from short oral regimen are eligible for longer regimen, sir. Longer regimen is given for a duration of 18 to 20 months
Good.
with no separate IP or CP. We should start them with at least 4 drugs which contains all 3 group A drugs, levofloxacin, bedaquiline, linezolid, and at least 1 group B drug, that is clofazimine or cycloserine. If only 1 or 2 group A agents can be used, then both group B agents can be used, sir.
Okay.
If the regimen cannot be composed with only group A and group B drugs, then we can use group C drugs.
Okay. Just to add to this, in India, what we do is we try to add all the 5 drugs from both Group A and Group B in longer oral regimen. So that's been regularly practiced in India also. Okay, good. Can you tell the dosage of these drugs?
So dosage is based on the weight.
Very good.
Weight-based regimen is what we use. And for linezolid, we start with 600 mg, but after initial 6 to 8 months duration, we taper it down to 300
Very
mg.
good.
Apart from that, we have dosage of bedaquiline. For bedaquiline, the dosage is for a period of 6 months. The first 2 weeks would be 400 milligrams to be given daily along with the optimized background regimen. For the remaining 3 to 24 weeks, it is 200 milligram 3 times a week along with the regimen. At the end of the 6 months, bedaquiline would be stopped and the rest of the drugs will be continued for the remaining period of the
Very good.
regimens.
So as you rightly said, linezolid always we start with 600 milligram. We look for the toxicity, and if we find out adverse events are there, then there is always an option of dose modification, and you can reduce to 300 milligram. Okay, very good. Can you tell, are we using any injectables in these regimens, long oral regimen?
So we usually prefer oral drugs, complete oral regimen, but in case the regimen cannot be composed with oral drugs alone, then we can go for injectable drugs.
Okay, fine. You'd have heard about pyridoxine. Are we
Yes, sir.
using pyridoxine in treatment for these patients?
Yes, for all MDR TB patients, we use pyridoxine that is based on weight bands.
Very good. Before you start this patient on treatment, do you want to advise anything to the patient or speak in detail about the treatment?
Yes, sir. I will explain this patient about the nature of the disease. Since the cause of the disease is the prior treatment default, I will explain him the importance of adherence to treatment.
Correct.
And I will also explain the family members about the importance of adherence to treatment, and I will counsel them to get screened for
Good.
TB. And I will also counsel him regarding abstinence from smoking and alcohol because it helps them for a better treatment outcome and adherence to the treatment.
Yes, so it's very important to tell the importance of avoiding these habits which can affect the adherence to the treatment. Fine. Once this patient has been started on this short oral bedaquiline regimen, how you are going to follow up this patient?
So for this patient, uh, we will do sputum smear for AFP monthly from the 3rd month onwards, and then we'll do culture every 3rd month, and we will do DST only if the culture turns out to be positive at the end of 3rd month or later on, or if the smear turns out to be positive at the end of IP or extended IP or at the end of the treatment, sir. Other than this, we will do liver function test, renal function test, and then chest X-ray whenever it is necessary, sir.
Fine. So you understand that periodically you should monitor this patient to look for any adverse event, and if any adverse event comes, we need to catch it at the earlier stage. Fine. Are there any other modality of treatment for this patient?
So apart from this, we can do surgery. Surgery is usually preferred for people who have unilateral single lobe involvements.
Okay, very good. If this patient turns out to be resistant to fluoroquinolones and any injectable aminoglycosides, so what do you call them?
So we call them XDR-TB patients.
Very good.
And for XDR-TB patients, we will do the same oral same oral MDR regimen, but that will be for a duration of 20 months, sir. And the regimen will be changed according to the DST results.
Very good. So this is what has been followed now. But if you want to know some update, you can find out like WHO has recently come out with some definitions. They have come out with newer definitions called pre-XTR TB and XTR TB. So what they say is for those patients who are declared MDR-TB, and if we find resistance to any one of the fluoroquinolone or both the fluoroquinolone, moxifloxacin and levofloxacin, then we term them as pre-XTR-TB. The current definition which says as XTR-TB is only when a patient is resistant to either bedaquiline or linezolid or both. So this may come up in future updates even in our country and will come into practice also, but you should know this.
Okay, sir.
Can you summarize the treatment for this patient in short?
Yes, sir. The treatment for MDR-TB with short oral bedaquiline containing regimen is given for 9 to 11 months duration, sir. The treatment for long oral MDR regimen is for 18 to 20 months duration. Dosage of the drugs has to be appropriate according to the body weight, and counseling of the patient is important prior to anti-TB treatment initiations. So, pre-treatment clinical assessment and laboratory evaluation are also very important, and counseling the patient should involve adherence to treatment, and counseling of family members is also important. Clinical and laboratory monitoring has to be done during treatment. Those with unilateral resectable diseases are identified to benefit from surgery, and the patient's family has to be screened for treatments for TB and have to be involved in the overall management plan.